So I'm actually speaking on the application of telemedicine in pediatric retina and how we're moving from just focusing on retinopathy of prematurity to new applications such as universal screening. And so I receive travel from Clarity, and I actually have an equity stake and serve as a consultant for VisionX. So Mike Tracy and colleagues came up with the whole concept of telemedicine for pediatric retina, specifically retinopathy of prematurity, beginning in 2000, and later on this was followed up by the photographic ROP trial, the PhotoROP trial, which demonstrated that the equivalence between ROP screening using either binocular indirect ophthalmoscopy or telemedicine screening. And it's very important that people understand this. The gold standard is binocular indirect ophthalmoscopy. It has never been validated, not once in any study. We don't know how good people are. We don't know if you look at it, I look at it, and you look at it, if we get the same results. We don't know if any of us are any good at it. It's never been studied. In contrast, telemedicine for retinopathy of prematurity has been studied extensively, and we know a whole lot about that. So they showed the validity that it was essentially equal to binocular indirect ophthalmoscopy. Then in my trials at Stanford called Sundrop, which is more of a community outreach for underserved areas, we came up with the concept of treatment-warranted ROP. That's what I was screening for. I didn't have time for referral warranted. I just needed babies that need to be treated. And if they didn't need to be treated, I didn't care. And so that worked fine for that. And then we see the next major thing that came around was the Joint Statement Screening Guidelines. In 2013, actually New Year's Day, they released their data saying, hey, we're going to have telemedicine be an alternative to binocular indirect ophthalmoscopy in certain situations, and they came up, with the people who could do that. And then finally, Graham Quinn and colleagues have recently come up with the EROP trial, which was the NIH-NEI sponsored trial, which validated Anna Ells' concept of referral warranted ROP, which casts a little bit broader net, includes type 1 and type 2 early treatment retinopathy of prematurity screening. And this is your basic setup system. Right now there's only one camera commercially available on the market, and we all use it. And that camera, we use what's called a hub and spoke and store and forward telemedicine approach. And I'm the hub, or Mike Tracy's the hub with Focus ROP, or Tom Lee or Quinn is, in each of their respective locations. They're the rating center. And the spokes are all the individual NICUs that are out there, and they send in the information to us. And the store and forward component of it is that we take the image, and then we save it on the computer, and then we synchronize it to the server, and then it goes to my place. When I'm done with clinic, I go home and I read the images, okay? But I don't do it in real time. It's not like a Halo presence sort of thing where you're watching the baby. It's being done after the fact, much like a radiologist reads x-rays. They just stack them and rack them, and they go and read them later on, okay? So that's what we're doing, except we have a time limit because ROP can progress, okay? Now, this is just an example of showing the various different opportunities that can happen. These babies, I'm just showing a select time point. This is all one baby. I did it at multiple time points, and you can see that disease comes and then it starts to go away in this child over time. And if I can get that video going there. And so, so this is just a baby where eventually there's spontaneous regression. So you can follow a baby that develops ROP and then gets better. Then you have babies that develop Avastin, the need for Avastin or treatment, okay? But Avastin is something that could be followed. And you can see here at 10 days after Avastin that you're actually being able, I think you can. And then this is one with laser, okay? And I always used to be skeptical about following laser on the camera. And the reason for that is because the camera is in 2Ds and laser is in 3D, right? And you don't know if you're developing traction or if you're developing the need to go in and actually evaluate that baby and relieve all these things. However, it's akin to one of the great ironies is that there's this whole community out there that says, oh, no, you've got to do binocular indirect ophthalmoscopy. It's got to be 3 dimensions. You got to see the entire eye. The reality of the situation is you don't have to see the entire eye. All treatment decisions are predicated on zone 1 or zone 2 or the presence of plus. Current systems are 130 degrees. They give you 65 degrees on either side of the nerve. You can see all of zone 2 reliably with one shot centered on the optic nerve in every baby. And everything after that is not a treatment indication at that point. The other thing that I found ironic was that while we go ahead and say that you have to do binocular indirect ophthalmoscopy, how we know what the classification of retinopathy of prematurity is based on the international classification of ROP. And all of the standard of what the disease is based on two-dimensional photographs. This is what it is. This is zone 1. This is zone 2. This is stage 1, stage 2, stage 3, stage 4. So if we're showing that this is what the protocol should look like, and this is what the baby should look like, and the disease should look like, and the extent of disease is an APROP with photographs, it seems to me that we should actually be screening with photographs that are similar to those standards. So at Stanford, we've been 11 years. I've been a little lazy. This is only through 6 or 7 years of follow-up, but the numbers are pretty hard to beat. 100% sensitivity, we find all disease. 9.8% specificity. We have very limited false positives. We've got a high positive predictive value. We've got close to 1,000 babies enrolled now through 11 years. So the real question is, you know, pediatric retina guys, we get bored. You know, we're like, okay, we got our OP done. What are we going to do next, okay? And one of our problems is that we get the babies too late. They bring a baby in, or a 3-year-old in, or a 5-year-old in, and they got persistent fetal vasculature, they got cataract, they've got X-linked retinoschisis, and there's not much you can do. It's ocular taxidermy at that point. But had we gotten the baby earlier, there's a decent chance that we could restore structure, restore function in a lot of these infants. But the reason is that in America, we don't screen babies. The first formal screening examination occurs by age 5 in the kindergarten. Now, we go and look at it here. What does the American Academy of Pediatrics have to say on this? They state that every child at every, and this is not every baby, this is every child, at every well-child exam till the age of majority, age 18, has to have a red reflex exam. I didn't know that. I found that out about 4 weeks ago when I was putting this talk together, okay? Additionally, they go and state that every child has to have a hearing test to look for hearing issues by day of life 30, okay? Now the reality is that when we compare these, this is the relative sophistication of these two tests. On the left, you got a computerized evaluation of the auditory brainstem system, and this is, well, this is a red reflex exam done by a pediatrician. Now as an ophthalmologist, I felt a little affronted by that, and I think we could do better, okay? And sure enough, we have the ability to do better, namely with wide-angle digital imaging. This is old. I don't use these kind of speculums. I actually use Alfonso speculums because I like the spring action, gives you a little wider, you can control the baby. But what we're doing here is we've got a wide-angle camera, we're centering it on the eye, and we're getting the standard protocol photographs. And what are those protocol photographs? Nerve-centered, up, down, left, and right. And then, on top of that, we're adding another photograph, which is a full facial photograph. And that's to look for dysmorphias and genetic issues and what have you. That nurse's very first
from the left to the right.
And
There?
still to this day, I marvel at that because I can
those
read
are actually
that
good
image
for her.
offhand and say, okay, yeah, we're good to go on that one. Baby doesn't have any ROP. So, this is not an original idea. You know, what is it Steve Jobs used to say? Good artists borrow, great ones steal, or the Picasso, whoever it was. So the Chinese, Li Hong Li over in Kunming, and then we've got Homero Miranda down in Brazil, and we got our friend over in Barcelona. And these people have been doing this for years, 5, 6, 7 years. And they collected a lot of data, and it was all very concordant. What they showed is that between 10 and 20% of babies at birth had hemorrhages. 1 to 2% of those hemorrhages were involving the center of the vision, the fovea, and they had a 1 to 2% non-hemorrhagic pathology hit rate, which is impressive. But it wasn't really a study. They were just doing it for cash or for whatever, as an extra service. Now, Claire Gilbert in the UK comes up with the whole concept of preventable blindness in primary prevention, secondary prevention, and tertiary prevention. So primary prevention is preventing the disease. So if we do screening, can we prevent the disease? No, that ain't happening, okay? Maybe, you know, in Star Trek in a few years, you take that little pill and all your cancer goes away, whatever. We don't have that technology today. So what we're talking about is secondary prevention, which is identifying, can we prevent blindness from the disease that's there, or tertiary prevention, which is preventing complications from the disease that already caused blindness, whether it was congenital or what have you. So we're on the secondary and tertiary phase, but who knows, at some point in the future, we may be able even to bring it into the primary prevention mode, okay? So what do we got here? We got like a persistent fetal vasculature, we've got a retinoblastoma. I mean, if you do universal screening in the United States, there's 4 million live births every year in the United States. There's 300 cases of retinoblastoma, putative incidence of 1 in 20 to 1 in 30,000. You could pick up all of these, and I'll tell you why. When you go to the concept of hearing screening, it really doesn't make any sense from a socioeconomic viewpoint. If we go back to Bayes' theorem, it shows that to have socioeconomic benefit when you're screening, you got to have a disease prevalence of about 2%. So what about it? What is it for hearing? It's 1 to 6 in 1,000. And that's not, eventually, there's a lot more people who end up with hearing problems. But the key word there is eventually, because hearing is a progressive neurologic problem. So if you screen at birth, you're only going to catch 1 to 6 in 1,000. And if you screen at age 4, you might get up to 0.5% or 0.75%. And your yield gets higher over time because the deafness gets worse. That's not the problem that we have. Almost everything that's actionable in a child will be present at birth, okay? That, you know, that we can go in. And the other stuff that isn't actionable will also be identifiable, okay? Can we do anything about the nerve? No. Coloboma? No. You know, if you don't have an eye, we can't do anything about that either, okay? So, myopia after laser photocoagulation, obviously this child would already be in the system. You got a hemorrhage from unknown pathology. We know that if you leave a hemorrhage alone for 8 weeks to 10 weeks in a monocular hemorrhage, you will induce myopia. It will not be mild. It can be very severe, minus 12 diopters in as little as 12 weeks. We know if you have binocular hemorrhages, you want to intervene by 12 weeks. We can do all of that stuff. But if this child's showing up months later, it's like we can't offer an intervention for them. So this is all hypothesis. And so at Stanford, we do stuff scientifically, or at least we try. And so we came up with a trial called the NEST, where we use them as the baseline, and we studied multiple different outcomes. One of them was, do we have a similar pathology incidence? Can we identify the babies in the same way? Can we have different sorts of graders identify? We actually evaluated the scientific process of evaluating the process. And one of the things that we looked at was this universal screening of red reflexes by pediatric people. And you're going to say, well, you know, it's a quick and dirty test, and you know, it doesn't require a lot of effort. There's 96,000 pediatricians in the United States. There's 4 million births a year. Almost all of those kids survive into adulthood. So in any given 18-year cohort, assuming you have 6 well baby exams in year 1, plus 17 years of 1 exam a year, so 17 times 4 is 68, plus 6 times 4 is 24. That's 92 million red reflex exams. You better have something worthwhile coming out of those 92 million red reflex exams, or why are you doing that test, okay? So it's interesting. There's this protocol photographs. You got the external, and then you got the nerve that I showed you, plus the full facial photograph. So we had 202 babies enrolled prospectively in year 1, and this is very reminiscent of a Northern California, near Stanford sort of population. We have a slight male preponderance. We've got a mild Caucasian predominance, and it's a 60-40 split on vaginal versus cesarean section, okay? So one of the outcomes that we looked at was, hey, whether or not we agreed with what we saw in photographs versus what the pediatrician documented in the exam, okay? So this is the old, basically crappy EHR system that Packard had, and this is where they documented now, you know, where they put their thing in the test, and now they've got the now even kind of worse system, Epic, but we all in some way or another have to deal with our own, you know, electronic medical record system. But this is what they had, and we went through there, and it's interesting because 100% of the babies are supposed to have a red reflex examination. So these are all the exams that they documented. These pediatricians were quite busy here, okay? They did external examination in 90% of babies. They did a red reflex in 96% of the babies. Actually, this was in way more than that. This was a 99-point-something percent, because it's 201 out of 200 babies, 202 babies. This one they did in 96% of the babies. They did pupillary exam, extraocular motility, and then this other is when the pediatrician got really brave and took up the direct and actually looked into the eye. Lord knows what they saw, okay? So the only one that they found an abnormality in was the external examination, and we'll talk about that in a second. Everything else was graded as normal, okay? So let's see if I can get to, and then of course they didn't do the 4% for the, so what did they find, okay? The most common finding they had was scleral icterus, 6 was lead edema, conjunctival hemorrhages of various sorts. The only ones that we agreed on were the lid edemans, the conjunctival hemorrhages. We went back, there were no cases of bilirubinemia, there was nothing like that, none of that correlated. So when you look at the kappa, and I don't know how familiar you are with kappa results, but 0, anything above shows some form, anything above 0 shows some form of agreement. And then they grade it, mild, moderate, high, near perfect, okay? 0.05 is slight agreement. And then when you look at the percentage of positive agreement, it was terrible, okay? That means that even when they identified disease that we agreed on, they were wrong on the diagnosis, okay? And then we go over here. This is the kind of stuff that they graded as normal on all of their evaluations that they didn't see. We had almost, 20% hemorrhages, foveal hemorrhages, optic nerve hemorrhages, conjunctival hemorrhages, choroidal nevi, group pigmentation. The mantra, when I was a fellow, a resident, as a medical student, is don't worry about these hemorrhages, they don't cause anything bad. So if you go and do a study on that and go look for it, there's no literature on that actually. You can't find one reference to support that, okay? We still have a 1.8 to 5% case of amblyopia in the United States. Amblyopia means visual acuity loss of unknown etiology. Now all these hemorrhages are transient, they go away. Part of the study that we're doing is we're doing a tail end study. We've got 2, 3, 4 year follow-up. And we're only looking at the positives, okay? But we had 20% positives. And we're following them up, and we're looking to see what the incidence of amblyopia and strabismus is in that population, okay? And we're gonna see, we don't have that data yet. Now sensitivity for these guys was relatively poor, as they say. Combine that with a high false positive, a low positive predictive value and high specificity, and they just were kind of not really good at identifying disease. So when you look at hemorrhages, I alluded to it, 20% retinal hemorrhages, 16% of eyes, almost 3% are foveal hemorrhages, okay? Now you can argue about, hey, does a hemorrhage in the periphery cause a problem? But I can tell you, hemorrhage in the fovea causes a problem. You end up with, you follow these kids out, I've got lots of kids years out where we're starting to do autofluorescence on them that I saw when they were kids that had foveal hemorrhages, and you can actually see where there's retinal pigment epithelial dropout, but I got them plugged into pediatric ophthalmology early and often, and they started patching them right on, and these kids, they're 2020, 2025, they all have phorias, okay? But they have depth perception, they're good to go. So you can say, well, you're not gonna do an intervention. Well, my intervention is just handing them to pediatric ophthalmologist, say, good luck, God bless, okay? And that kid now maybe is able to fly, has depth perception, get a commercial trucker's license, whatever, okay? But they can be a productive member of society in that sort of situation. Now, we only had 201 babies, okay? So we're not gonna pick up in that small data set 1 to 2% non-ocular, non-hemorrhagic pathology, which in fact we did. We had the choroidal nevi, which we picked up, with group pigmentation and polar bear tracks. But you can see great asymmetry between the two eyes, okay? And you can see this looks like non-accidental trauma. It's multilaminar hemorrhages, they're white-centered hemorrhages, they're affecting the optic nerve, intraretinal, preretinal. This one's affecting the fovea on that side. So, timing. I always get it. I go into there and we're doing the study and they're like, oh, don't look at my baby. I was like, wait, you don't have to participate in the study, But they said, can you look at them in 2 weeks when they're a little bit bigger or a little bit stronger? So it's a valid question. So I was like thinking to myself, is there a way we can kind of indirectly look at it? Well, it turns out I had another cohort of babies in the sun drop thing. So I was like, let's look at the rate of hemorrhages on first exam, right? We'll see what their hemorrhages is. And my hypothesis was that would be pretty high, even though my gut feeling was it was gonna be really low. Why? Because I do all these images and I don't ever remember. For me, as a pediatric retina guy, I've never associated hemorrhages with retinopathy of prematurity, okay? Hemorrhages can occur after the ROP develops, but it's very rare to have it in the absence of ROP. And so we looked at it, and what we did is we had 2 cohorts. One is the original one. This is joint statement screening guidelines, right? 1,500 grams or less, 4 weeks chronological, or 31 weeks post-menstrual age, and then 1,500 to 2,000 grams felt to be at high risk by your local lawyer, okay? So those are where it was. And so in the term babies, we did only babies that were 37 weeks and above, okay? And screening we were gonna go between 0 and 72 hours, but the nurses wouldn't let me in to see the babies before the end of 24 hours. So basically we looked at them between 24 and 72 hours. And it really put a squeeze on me because on the vaginal deliveries, they're out the door in 48. So you got 24 hours to kind of seal the deal on that. And on the other ones, you got the full 48. So what do we see here? We saw 203 patients versus 73 patients in a year-over-year consecutive contemporaneous series between these two. And it's interesting, 20% of hemorrhages versus 1% of hemorrhages, 16% of eyes versus 0.6% eyes. And then, this is the key thing, resolution occurs by 4 weeks in these kids. So if you start looking at the hemorrhages, they go away in 4 weeks, which is something we kind of all knew. And so this difference here is just, I think, is that because we're looking later in this group, we looked at these at about a day, and we looked at these at 4.5 weeks. And at that 4.5 weeks, most of the hemorrhage went away. The one that we found was just the kind of leftover robust hemorrhage. But it does have bearing on what we're doing. And here, this just shows. I love all those zeros with having taken statistics classes. You see 0.001, it makes you feel happy that you did something important. Well, it was all very statistically significant based on just the chronological age at which time these babies were being examined. And so, one of the implications is no, we cannot screen your baby at 2 weeks. We need to screen your baby within the first 24 to 72 hours. In fact, even in that small data set, it was trending positive at 0.06 within the 48 to 72 hours. So even within that time, hemorrhages were going away, and it really mattered. The earlier you screen matters, okay? So now, I was talking about the scientific validity of the technique. So we started something as a subset of the NEST, which was called GUEST, which is the Global Universal Eye Screen Testing Program. And what we did there is we contacted Li Hong Li and said, please give me your baby images, and she did. And then we contacted Omero, and we did the same thing. And then we took ours, and we de-identified all these images, removed all the HIPAA information, and we dumped it into this big data set, which looks, this is kind of what all this stuff says. Oh, and this is like, we put it in there, and we're testing various protocols. We're in the process of doing this right now. And what we want to do is go and say, hey, because the government isn't going to pay for this right now, you got to go out there and you have to show a lot of studies, then you have to show it works, and then you got to show that it's reliable and reproducible, okay? And so to do that, what you want to do is, when you originally start out, this is going to be something that you charge the parents for, okay? You're going to go say, hey, 50 or 100 or whatever the price point is. But if I'm paying for that to tell you whether or not your baby's eye is normal or abnormal, I better be right, okay? I better be right most of the time, okay? And so, otherwise, they're gonna be mad at you, right? And so, fortunately, most of the stuff is gonna be in the center field. You're gonna get all congenital glaucoma and cataract and media opacities. You're gonna find out if there's, anything affecting the back. Most retinal blastoma in babies will be in the posterior pole. It only progresses peripherally as time goes on. So you're gonna pick up on a lot of that stuff. And this just shows the various things that we can do. We could just do a single shot with the nerve centered. We can have all 6 photographs in there. We can do with and without high mag, and we're trying to test that. And what are the things that we're looking at when we're testing? You guys need a Mac. That would make my life, okay? So, first of all, REDCap is just a standard across academic institutions where you can have all sorts of HIPAA compliant information de-identified in the database. We put it in there. We're double masked. I don't know the baby. They don't know me. We have multiple different screening protocols. Look at this. We got 90,000 images. That's a couple months ago. We have 5,700 babies, all in this database. It's the largest normative database on babies' eyes in the entire world, and it's very fascinating. So what I'm trying to do is to find the cheapest talent, okay? And I use that word cheap on purpose because we're in a dollar-constrained healthcare system. And however bad it is today, it's gonna get 100 times worse in the very near future. So what we have to do is find ways to have people who aren't necessarily physicians who can rapidly go through this and identify normal and abnormal. And we've got one major advantage here, which is 80% of the babies are normal. Okay, we know that right off the bat. 80% are normal, 20% are hemorrhages. We got 3, 2, 1, 3% are going to affect the fovea. So you can have pre-set up formats for those. We'll know in a few years whether or not the peripheral hemorrhages track with the amblyopia or not. Maybe they do, maybe they don't. It's a worthwhile question. We're going to know for certain on the foveal hemorrhages whether they track. And definitely on the normals, then all you really want is some sort of, at some point maybe you want to do an OCT because of Cindy Toth's excellent work showing fluid exists even in an attacked foveal reflex, okay? And that's all coming. But what you do is you start off tip of the spear, pediatric retina. There's 20 guys in the United States who do that, so you clearly don't want them screening. Pediatric ophthalmologists, you run these people through. There's, what, 2,000 pediatric ophthalmologists in the United States, 2,500. You got retina specialists, you got another 2,000 to 3,000 of them. But what you really want to do is get down in this territory, because you want to find out, can I get a technician or a nurse who can go through, I don't care what the abnormality is. I just want to know normal or abnormal. Because once you find abnormality, then you can start going up the food chain and finding someone who actually might have a higher degree of certainty in figuring out what the abnormality is. But as a first pass, I mean, I can tell you, I can do a lot of babies on telemedicine. There's 4 million babies, okay? If you're going to screen them all, it's not easy. And you got to have a lot of people out there doing it. You got to make it inexpensive. So, summary, 20% of babies have hemorrhages. 2.9% are involved in the fovea. Hemorrhages resolve in about 4 weeks. Optimal timings within the first 48 to 72 hours. Unexpectedly, at first blush, you know, preterm babies have fewer hemorrhages. Validation is possible due to international cooperation, and that's been the key here. The people who are doing the telemedicine have been very cooperative amongst themselves, because we're all interested in coming up with sort of a standardized protocol and a standard training mechanism, which is not something I've got into, but if you ever get a chance, go to the Focus ROP website by Mike Tracy, where they actually have training certification for grading of these images. And then we can identify disease early, intervene early, and then, this is the big one, possibly prevent amblyopia, okay? We don't know about that, but we hope to validate that in the future. Any questions? Thank you.